Are meal times a serious struggle? Does your child eat a limited number of foods? Does your child eliminate entire food groups? Are you tired of waiting for them to just grow out of it? Welcome to How to Unpicky Your Picky Eater, where you'll learn strategies to help your picky eater expand their palate. With Christine Marotti-Yoder, a pediatric feeding specialist, speech pathologist, mom of a child with feeding issues, and author of Mealtime Mindset. Let's get started. Here's Christine.
Welcome, everyone. Today we have Bella Rochford. Did I say it right?
Yes.
She is an OT and IBCLC and owner of Nurturing Lift. And she is going to talk to us today about breastfeeding, bodywork, infants, and all of the things in between with feeding. So did I miss anything? Did I leave anything out?
I mean, that's the too long didn't read version. That's perfect.
Yeah.
We'd be here all day if it was any other way.
No. So yeah, tell me like a little bit about like how you even like got into like, because you're very niche. You're very, you're an OT, but most OTs are not also breastfeeding specialists and, tummy time specialists and, like you very niche down. So like what got you into that?
Yeah. So I am an occupational therapist originally. Okay. So I always knew I was kind of end up in peds. I love pediatrics. But this is a niche that I certainly didn't anticipate until, as many kind of in this feeding realm find, the journey through parenthood and motherhood kind of open up your eyes. In grad school, I was actually very interested in this concept of occupational justice, occupational deprivation, which are terms that things in life that might take away from your ability to do day-to-day functions.
Oh, interesting.
Yes. So it was always one of my favorite, it ended up being one of my thesis to work on. This was prior to motherhood, and I was like, okay, this is, you kind of see this in every setting. In occupational therapists, we focus on function, activities of daily living. You could plug us in wherever we kind of go. That's why we look so different. And then motherhood happened. And as we know, there is such a gap when it comes to maternal health care, especially postpartum, even like looking fine-tuned. And I started to realize that pediatrics, especially the infant population, is so much more than just the infant themselves, the infant body, but it is all about how they are interacting with their parents, their caregivers. It's all about co-regulation. So I started realizing, I love infants and babies. They're awesome. They're cute, but there's so much I love about addressing the maternal health care aspect, which is when I started tying in the lactation, IBCLC component to everything. So it was a beautiful mesh of having this family unit as individuals and together meet their goals in terms of feeding. I only see 0 to 6 months old. If I do see a little one outside of that box, they were usually a previous client just to make sure everything's good, but I only do breast and or bottle feeding. So I really niche down because it is in the world of pediatric feeding, it's 0 to 18 years old. There's so many ways that we can go. And I know that we each in the feeding have to niche down in a way.
Oh my gosh. And it's so different for each of those age groups. Even after 6 months old, everything changes when they start solid. So you have to learn a totally new skill set. Like it's crazy. Like, so to think, even if you took one class in college about it, it is so not enough, right?
It's not enough.
Yeah.
It's wild because you enter the feeding world, I think pediatric feeding, and you're like, oh, okay, here's a general course. And then you see how in-depth every topic can be. And the extent of adding in the lactation component and how that dynamic is happening at the body is just, it's like two working puzzle pieces at once. So it's really, you're constantly on your toes. So I love it. I'm more than happy to just like being in just that niche. There's so many different scenarios that can play out. So that's a little about how I kind of got into the lactation. I think working in that 0 to 6 month population, definitely it's recommended, but there's a strong component of being able to navigate the lactation world with that population.
Yeah. And they're so complex. And like you said, like there's like cardiac patients, and that's its own thing to learn, and all of the nuances of them. And then there's babies with syndromes, and then there's just typical babies who might have tongue ties and are otherwise healthy, and then there's immune deficiency baby. Like there's so many
different
things that, you know, you could like specialize in even just one of those and you would be like so busy. But
oh yeah and I tend to see, I do, with my OT background, I did some acute care. So I do medically I do tend to have a lot of medical complexities, whether it's post-cardiac surgery, syndromic, but also in terms of biomechanical, oral skills, head to toe. Feeding is full body. And I know it's kind of what we're going to talk about today, but really how even something like a head turning preference or torticollis can just throw off the entire feeding process. So there's so many different avenues. Yeah.
And you know what? Let's start there with torticollis, because I find that it's like almost, I don't know if it's underdiagnosed, but I find I ask parents about were they diagnosed with torticollis, and they say no, but they actually did have a head preference, or I noticed that they have a head preference or a C curve, which you know, like was like when their body kind of almost makes that C shape. But it's like, you know, like, well, why isn't that being like, what do you think about that? Like, why aren't doctors even noticing, or are they just not trained well enough to even notice it? But that's like a sign that we look for that I feel like is missed.
Yes. Oh my gosh. So torticollis is one of those things where it's a buzzword. Okay. So buzzwords can be helpful and they can be harmful, I found in this thing, because it's depending on, remember, infants aren't in a vacuum. They're not an island. Kind of joke. They're like an archipelago. They're a bunch of islands. Like they need their caregiver. So when we're talking about infants and anything that is not optimal, we always have a caregiver that is there and emotionally invested in this process. So a buzzword like torticollis can seem really scary. So how I always talk to parents and look at babies in general is I don't try to put that buzzword on right away. What I say is, oh, baby looks like they really like looking that way. Are they really good at looking that way? But the other way you see less, or I could see that they're still going that way, but they really tend to be stronger that way. And parents are like, there are no like alarm bells, like, oh my gosh, there's torticollis. And you hear all these, like, there's scary feelings with that. So we kind of talk from a symmetry perspective. So I do think that you kind of get this wide array. If it's not a kid stuck, like the little one stuck like this, that, oh no, it can't be torticollis. But beyond torticollis, which is more focused on the C-spine and the neck, you get tortisoma, or like the body asymmetry. So that's really what I'm focused on. I say the body is a house. Okay. Our head, our neck is the most obvious. It's like the roof of the house. We tend to notice the roof. The roof has to get repaired. But what is our neck connected to? It's the rest of our spine and our pelvis as the foundation. So the first place I look in terms of like that torticollis is usually not directly at that asymmetry, but what the pelvis actually looks like. What baby has that cute C? The C has a bottom to it too. So usually what stems from what's going on up top is something just a little out of balance. Baby really likes going one way in a side bend versus another. So we start there. We look at it at a point of what baby's strength is, and let's try to get them really strong going the other way. It just sets up a nicer conversation with, like, if a little one is labeled torticollis, it's usually, okay, now they're stuck here, now automatic helmet. And it's usually not the case.
Yeah, see, I wouldn't think automatic helmet either.
It depends on who the practitioner is, but you'll usually get, and I love pediatricians. They should be referral wheelhouses. They're integral members of the care team. But whenever we get a case where torticollis usually goes, oh, okay, baby's showing a really significant head turning preference. Okay, increase tummy time and let's wait and see. Let's wait till 6 months old. And then it's like, no, earlier is better. So that asymmetry is going to lead to compensations in the body. Babies are smart. They're going to learn to survive and thrive with what they're able to do. So if we need to compensate because our head is stuck one way or another, then we're going to build all our skills around that asymmetry.
Right. And then I would imagine that affects feeding.
Oh, yes. Yeah. Feeding doesn't just happen in our mouth. Feeding is a full body experience. So that's where we I look at baby head to toe. And then when they're on mom's body, their parents' body for breastfeeding, then we're seeing what that natural asymmetry is happening. If I find that, oh, it's really hard latching Johnny on the right, but left isn't so bad, then I'm like, okay, is there an asymmetry that's at play here? Is that what is impacting what's going on? It's not an automatic, truly simply just oral motor skills issue. It's usually just what's happening in the body. It's not, oh, it's ties is affecting, that's why. But it's the whole body system at play.
So of course, this is a picky eating channel, but have you ever had picky eating babies?
Yes. So as an OT, I love and respect the nervous system and sensory system so much. So what I always say, because I oftentimes don't have just first-time parents. I have ones, I get a lot from older nurslings. Oh, my 4-year-old's doing this. Like, what's going on? Oh, yeah, I'm like, oh, are they very selective about what they like to eat? Do they avoid certain foods? Usually what I see as selective for little ones, that I say they like to be wined and dined, they like things just right, a certain temperature, is a sensory preference. So from that perspective, the tongue is supposed to be constantly in contact. Physiologically, it should be in contact with the roof of the mouth. When that's not happening, and not happening frequently enough, whether at the roof of the mouth, the bottle, the breast, what is then happening is that surface area that's supposed to be touching or in contact frequently is not getting that. So naturally, there's going to be more of a hypersensitivity. So how I usually say that, I see pickiness manifesting is more sensory preference. There might be hypersensitivity. I sometimes occasionally we get the hyposensitive, where kids just need a little bit extra oomph, a little extra flavor. But usually in this 0 to 6 month, especially 3-4 months, when they start to really become more aware of their surroundings and less reflexive than those early newborn days, is that they actually might feel that sensation of, oh, that milk touched my tongue, or that part of the breast touched an area where, it's really sensitive. I'm going to back away. So what I usually end up saying for families, before you can do good, you have to feel good. So before we address the motor component, we have to address that sensory. And more often than not, when we work on strategies of, I wouldn't say desensitizing, but bringing down that hypersensitivity and that alarm bell, fight or flight bell that's going off in baby's head, we get them comfortable with doing certain optimal movement patterns in their mouth. So yes, I see the selectiveness in that early time, but more so it usually is a little bit of a yellow flag in baby is not moving parts of their mouth in the most optimal ways.
Got it. And I mean, that makes so much sense. And a lot of times when we get them as older kids, there are those red flags from when they were infants. Yep. And they were selective, and they did have preferences. I've heard so many times, well, they just didn't like the bottle, or we had to go through so many bottles before we found the one because they were so picky.
Yes.
And it's I feel like it's more, well, you said sensory, which I think is so good too, but it's like, well, maybe their tongue was really not functioning optimally, and it was just really hard for them, and it was just a struggle. And that might be why they might look selective or whatever, as a baby.
Yeah.
But it's that tongue function, which you said it's supposed to be on the palate the whole time. Yep. And I wish that was part of a screener at the hospital or with pediatricians, that they were looking for that at birth. Maybe they will at some point.
I know Brazil does a lot of newborn screening when it comes to that. But I think we have a ways to go.
Yeah, we do. And, a lot of times, sometimes we'll have parents that they'll say, oh, yeah, they had a tongue tie when they were a baby, but it was released. And then I say, well, did you do any body work? Did you see a chiropractor, an OT or whatever? And they say no. And I'm like, oh, what, like what a missed opportunity, because that isn't right. Isn't that like really the best time to work with someone like you?
Yes. Yeah. This is one of those topics that can be very charged in the lactation and feeding world, for that very reason of timing of everything, what's indicated for what baby, body work, what is body work? Did your baby get body work? Are they getting body work? We kind of get into that. It's a rabbit hole for sure.
Yeah. And it's just like a big term. It's like, well, what does that even mean?
Yes. Okay. So I am just one clinician. You will get so many different explanations, but how I explain to families when I hear body work, there are kind of two schools of thought. It's a catch-all phrase. It's like this big umbrella term, kind of like torticollis. It's a buzzword. You hear it in the field. Body work. Did your baby get body work? Essentially, what it boils down to is, did someone work on your little one's body, with their body, in order to optimize where their function and their skill or their alignment and symmetry is at any point? And if there was a frenectomy pre or post release, that's essentially what it is. What you oftentimes get is it's synonymous with a specific modality or specific framework. So usually I find parents say, oh, like we did body work, love chiros. Chiros, one modality that you tend to hear, craniosacral therapy, CST. Mm-hmm. Those are the two main ones. But OTs, PTs, even SLPs. I mean, there are nuances to the modalities you can use on the body. So what I usually explain is, in my practice, I work with the body. Okay. I don't do to the body. I do with the body, because it's just from a motor learning. Yeah, I know. I was like, from a motor learning perspective, any active process in the body is just going to go so much better to have for long-term gains than doing just passive stretching. We know this from understanding physiology in the body and function. So the two schools of thought you tend to run into with body work is, I need to do this so that I'm checking the box and I'm doing to their body, and doing for their body. Now, each practitioner is different where they kind of land. I consider myself, by nature of that definition, a body worker. I don't do chiro. Chiro is their own scope of practice. The modality, I don't use CST. Myofascial release is MFR. However, I use other modalities that include neurodevelopmental treatment strategies, movement patterns, total motion release by Suzanne Blum, or Bloom. I might be messing up the name, but Suzanne Bloom. I took one of her courses there, and that was really intriguing way to look at the body. So primitive reflex integration is another one. There are a lot of different ways you can address the body and work with the body. So I really try to maximize how we're moving through it. So for that umbrella catch-all term, it's really going to mean, can we get baby functioning more optimally in where they're at in their current status, and how can we set them up for long-term gains?
Yeah, I think that's so important. And, I think, even to some degree, babies come out and they've been constrained and confined. I feel like, to some degree, wouldn't it benefit every baby, even just for even 1 or 2 sessions? Like, I feel like, why not?
Oh my gosh, yes. I've spoken to colleagues about this, and coming to timing and body work, there's this notion that when it comes to just the frenectomy world in general, I don't know if it's just something that is perpetuated in terms of families realizing, oh, with my first, or I was told to just wait, and now we have this idea of sooner is better, and sooner doesn't mean better. Sooner doesn't mean better outcomes. So what we tend to see in that first 2 to 3 weeks, and I see a lot of little fresh newborn babies. The 0 to 2 years old, I think my youngest was 16 hours old, which was a pleasure and really cool. But we tend to see a lot of that physiologic flexion. So that I have my little baby here, that cute curled in utero positioning. There's so much midline, for lack of a better word, tension. There's so much flexion in this pattern. If they come out of that pattern, what happens is some of their other reflexes happen, their startle reflex. So babies are going to thrive in that flexed pattern initially. So sooner going for, say, a release, you're looking at like what you're doing to the middle of the body doesn't necessarily equate to if we're not adequately preparing for little ones. Now, it'll go into the school of thought of, well, like for breastfeeding, we want this nice wave-like motion for the tongue. That's the most important, this wave-like peristaltic movement. We want that middle of the tongue coming up and creating that vacuum seal. So some release providers will say, look, naturally that's supposed to happen. So we don't need wound care. They're good. They don't need the body work. They don't need wound care because their body's naturally going to do this. And I have seen revisions, which means release after getting another release after the initial release. So I've seen revisions where that it might be a function of the time we're living in. It might be a function of genetics, epigenetics, in utero positioning, lifestyle, where little ones' individualized approach is key here, because little ones may physiologically be primed to do that movement, but can they? Or do they have too much asymmetry in their body, too much tension? If I have a significant turning preference right out the get-go, babies just like all this and all their sonos, what their frenulum is doing is not the first line of defense. So if their tongue can't go up all the way and they can't do that active movement process, then we need to introduce that work on and with their body.
Okay. Got it. Yeah. So sometimes it's like not always like, you might not want to be fresh out of the gate with them.
Yes.
Okay. Like they were just born. Let's like get this, I think that's why it's really important to find a provider or someone like you that could really be like, you know what, now is not a great time. Let's see in 2 weeks or try this strategy. And then like, let's prepare them the best that we possibly can and then go into it. And then after period too, it's like that relearning because they've been in utero swallowing for many, many weeks. If they've been swallowing incorrectly, they kind of have to relearn that.
Yes. Yeah, that's absolutely the whole idea of it, that the fancy term of neuromuscular reeducation, that brain body connection has to be reestablished in a way that we're trying to do. So my spiel that I give to parents to help understand is I am not one for wait and see. I don't think wait and see is effective. I say what we're doing right now is we're pausing and we're preparing for if or when this is more appropriate in time. This is not a matter of months. In baby time, days and weeks can feel like a very, very long time. But what we're doing is if we decide to pause a specific release consult, we know it's kind of on the table. It's never fully off, but we're doing steps to always be improving function right out the gate. So we should always be seeing and moving forward up until that point. So it's not like I'm saying, okay, time to sit on our hands and wait for that clock to run out until they're out of that physiologic flexion and now it's go time. What we're doing is we're getting foundational skills going. If it's a first-time parent that's never breastfed before, or even if it's a second-time nursling and they are just different from the other one, talk about what is happening at mom's body. We're talking about what is happening during that breastfeeding session, where if we can fix the little things, sometimes at least that buys time. Damaged nipples, we got to take care of. We can't have that going on. So usually we can fix within 24 to 48 hours some basics and get them to skill building. So whatever tools we're putting in our toolbox, we're moving forward and we're moving towards if frenectomy consult is inevitable. So moving that body, going to chiro, adding a different modality in. Some babies might need one, and that's where that individual approach really helps in this situation.
And now, what do you think are like signs? Like, so if someone's listening to this and they're like pregnant, or maybe they just had a baby, like what are like the signs, or like maybe if a doctor's listening, like what should they be looking for? Like you mentioned the nipples, which but like what are other signs that like, that their tongue and really the rest of their body isn't working as well together as it should be, so that everybody is comfortable and less stressed out. Because I'll tell you, you probably know there's nothing more stressful to a parent who's tired, exhausted, and then their baby's screaming because they're not eating and they're uncomfortable or colicky, right? So like, what are like the signs, and like, how long would you really wait before you like made that call? Like, what would you tell parents to like look for and when to make the call?
Yeah. So this is one of the things where you might get a different opinion on depending what people see clinically. But what I tend to do is I will set the expectation of options. Okay. So I can only bring my informed decision making of these are the signs that you're experiencing right now: cracked, bleeding nipples. Pain is always going to be one of the biggest flags on the parent's end, and weight loss or plateaued weight is going to raise flags more than a quick weight gain. Now, quick weight gain is going to fly under the radar and, oh, baby's gaining weight beautifully.
We hear that all the time.
That doesn't tell me. That tells me that we have to consider what the supply looks like, and possibly if there is suboptimal tongue function, that baby is overstimulating mom. So I actually see fast weight gain and like flying up the curves as a sign in and of itself, which not a lot of pediatricians will notice right away, because baby's gaining weight beautifully. Weight gain should be relatively like staying at the same rate. So for those little ones that gain weight fast, I tend to see higher reflux type behaviors. I call it the vicious cycle of reflux. My gauge is, can you get off the couch? Oftentimes these families will say, I feel like I'm feeding all day long. I feel like it's baby's never satisfied. Yeah.
That was me. I was like, oh my gosh, 10 minutes went by and he wants to eat again. What is happening?
He's insatiable. Yeah. I hear it all the time. So I gauge, can you get off the couch? If a family's like, I feel like we're cluster feeding all day long, we've kind of normalized certain kinds of cluster feeding. For small parts of the day, I understand it, especially when milk supply evening is going to be lower. But if you say, oh, my baby's cluster feeding all day long, like all day, every day, then I say, okay, let's look at what that behavior actually is. Is it hunger? We look at their body, their system. So if I have a little one that wakes up and starts screaming, they go from 0 to 60 screaming, we look at the nervous system too, because sometimes those little ones, you or I have nervous systems that kind of get used to the outside, but the sign I would look for is 0 to 60 feeding. So if that little one might take a little bit longer for their hunger cues, it's called interoception. Your ability, bowel, bladder, tell us if we're full, if we have to go to the bathroom, if we're hungry, full. Some little ones might be less responsive or hearing that sense. So if they go from 0 to 60, we want to see, okay, is it that they're sleeping through that? Are they having reflux? There's so many different dynamics that a functional assessment has to take place first. So I don't expect a doctor in a pediatric wellness visit to be able to screen all these things. It requires an extensive evaluation of looking at function. You can't just look at the structure too of if a frenulum looks like it to the tip or not. So that's only one measure of like how far we can go for signs. We have to look at both in a breastfeeding relationship, both mom and baby, and if baby is exclusively getting bottles, we have to look at what's going on during a feeding session. So there's so many different signs that can tell us function isn't optimal. That's how I say it. It's not, oh, there's a tongue tie. It's that tongue isn't doing what it should be, or that cheeks, nothing is kind of working in the way that it should be.
Right. I know that and you know, when I, like you, I got into feeding because of my son with his feeding challenges at birth. And then, but I didn't even know that some of those things were signs. You know, I was like, well, I guess he's just a fussy baby, but it's really like, no, like, okay, excessively fussiness, that is a sign that something else is going on. So, you know, it's not just like, well, he's new baby, like expect them to cry. Like I feel like you hear that, like as if like like you said, it becomes normalized. well, of course he's crying. He's a new baby. Like, it's like, no, like of course he's hungry all the time. He's a new baby. But it was so much more than that.
Yeah, I always try to come at it from perspective of, I have like my little like colloquial sayings. I think what happens in the infant landscape, that just we're so focused on doing right by our babies. What happens, two things, and it happens from other parents, other family members, friends, pediatricians, doctors, you name it. We normalize pathology and we pathologize normal. Okay, so yeah, I like it too. It's an example. I'll give an example of each. So when we normalize pathology, colic isn't a diagnosis. Colic is a sign that something is inherently not going optimally through a process. So pathology is a strong word, but colic would be something that we have now said, oh, they're just a fussy baby. Your baby's just fussy. Like, they're just colicky. That's just what it is. Not only are we normalizing,
well, there's nothing you can do about it because you just have a fussy baby. That's your problem.
Let's try reflux meds, or let's try if a parent is breastfeeding or giving breast milk. It's like, oh, it must be the breast milk. We should try formula. And it's like, we've just kind of go into like, what's this? It's almost a gaslighting kind of thing that we're going into, of like, just wait it out and see, or let's just try, let's not get to the root cause. Let's see what, like, we're just putting Band-Aids on bullet holes. Then you have the alternate thing, which I think in the feeding realm that a lot like you and I, and we're trying to kind of counter, is pathologizing normal infant feeding norms, normal infant feeding behavior. So an infant that might be eating sooner than 2 hours, but is transitioning nicely from a sleep state and showing all the hunger cues, just because they haven't hit 2 hours or 3 hours, or, oh, I can't get baby longer stretch than a certain amount. That's not something's wrong with baby. That's just us trying, from a societal perspective, putting an unrealistic expectation of a certain schedule. So does it work for families? Yes. And that's where we have to consider like where our families are at. But it's something where something is wrong with baby because at 2 hours, they can't get a stretch of 2 hours, 3 hours versus 2 hours, if that makes sense. So when we have those two things, normalizing pathology, pathologizing normal, that's where we have to start teasing apart and validating a parent's experience that they're having.
That's a really good point too. And I find that like even with like the sleeping, sometimes parents will be like, well, like, you know, I better start sleep training them because I gotta like get back to work or something. And it's like, you know, like, well, that they just might not be ready to sleep through the night, you know, at 12 weeks or whatever it is, just because like that's what you want in your schedule doesn't mean that that's what baby wants, right? So like, is that kind of like what you mean?
Oh, yes. Yeah. I end up setting up expectations a lot, whether it's feeding, sleep, play related, is that there are two roads you can kind of go down, because this is all, remember, coming back to the family unit here. It's just not one individual like you might see with adults. We're coming back to the family system. So I either say that we're going to baby's going to adapt to our structure, which is going to be more schedules. And that's where you will see more of that, like having to be in a certain sleep regimen, feeding regimen. Is it to baby's norms? No. Is it to allow that family to survive through society's expectations? Unfortunately, might be the latter. So if we're expecting parents to go back to work so soon after giving birth and they're already sleep deprived, it's a bigger issue than just what is that infant doing.
Right. I know that could be like a whole other conversation. Oh my gosh.
That, because that's a whole, I mean, I'm sure that also plays into like the picky eating aspect of like little older kids, like how long mealtime can take. But the other option is that baby, we adapt to baby. Less structure, much harder maybe in the way society has structured things, but we're going with a more infant developmental norm. So waking up 1, 2, maybe even 3 times a night in the first year of life still falls in the realm of typical. I tell parents that, I'm like, 5 hours is sleeping through the night. Baby's doing 5 hours, fantastic, really good. Like, I'm really happy. If I have a little one, another red flag, if I have a little one that is like every hour on the hour they're eating, that's something where that's not sustainable. So we recognize where we want to try to fix it and what is developmentally appropriate.
Right. But it's so important because, like, there really isn't anyone telling you, like, okay, well, like, this is normal, but this is not normal. Like, like, even at well visits, they're not necessarily asking every teeny little question that might make them think, oh, wait, that doesn't sound right. It's just like, are you getting sleep? Is baby sleeping? Great. Okay. But it's like, oh, well, yeah, but oh, you forgot to mention that, like, oh, well, they sleep, but they wake up every hour. Like, that's very different.
It's too much for pediatricians, honestly. Whether it's why I really truly believe the referral wheelhouse, they should be automatic out to specialists would be the thing, because you just can't keep up with the nuances of every single aspect of life.
Yeah, it's just, there's just so many, and feeding is so complex.
Oh my gosh, yes.
Yeah. And I would say also, right, another sign would be, this happened to me a lot, but he would take a lot of breaks. Like, it was like he almost had to take a break to breathe, and then he would go back to feeding. And at the time I didn't know what that was. I was like, oh, he's just taking a break. But it's like, they should be able to maintain breathing and they alternating like in a natural rhythm. We call it the suck, swallow, breathe. Right. But I didn't know that that was what it was at the time. I was just like, oh, he's so cute. He's taking a break to breathe.
Yes.
No, this wasn't cute. That was bad.
Yeah. Well, that, I think you touched upon the kernel of what I try to bring home to every family, because feeding is such a really starting out primal activity. It blends into like this beautiful social, like mealtime culture, everything. We have to remember what is also shared with our feeding, and it's our airway. So if we have a little one, and depending on mom's supply, depending on what the parent is at, and this is where breastfeeding knowledge really and lactation knowledge helps, is if that baby is like, say, you might see a jaw quiver, that's muscle fatigue when they're at the breast, okay? So if you see a baby that's constantly like chugging, I love my analogies. I always bring it up. Imagine if someone put a hose and you had a robust supply, someone turned the hose all the way, okay? Even the best of us that can keep up initially need to take a break, because we need to protect our airway. So ultimately, if we're just holding on, we're going to come off. We're going to find a way to survive and thrive. Same thing for babies. It's airway management. The thing with tongue ties, if the tongue isn't resting, we're not shaping the palate. Tongue is nature's palate expander, and the palate is nature's tongue scraper. When we're not expanding that palate, we're not allowing optimal breathing through our nose. Okay. So that high palate it's all connected in a way that ultimately we have to look at what our airway is doing. So beyond just feeding, which is like a really crucial key, is can we look past that for say a little one, 4-year-old that's more selective in eating. If they had an earlier sensory preference or selective preference, their body over time might start to say, hey, this might be a dangerous thing. This could compromise my airway. I'm going to avoid this now. Then it becomes behavioral. So if we bring it all the way back, that's why we always try to have that nervous system, that sensory system in a calm place, whether through working with the body. Okay. So we did a full circle coming back to like that body work, but looking at the how comfortable and regulated a little one is during a feeding. That really is going to tell us the moving parts of, is manual therapy, hands-on therapy indicated? Are they hitting a structural limit and they physically can't bring the middle of their tongue up anymore? Is it a combination of both? Usually it is. So there's so many moving parts that it really, the best place to start, and the part that usually takes the most digging for parents, is getting past that, oh, they're just going to be that way, that's just a baby sign, and finding someone that can assess all the functional components and send them in the right direction.
Love that. And one more thing I want to bring up before we go. I know I've had your ear for a while.
Yes.
But is that like that connection and the stress. And, you know, I learned so much about how basically babies can feel our stress and how the parents' emotions actually impact their mealtime.
Yeah.
And like if you are constantly like, did you eat enough? Did you eat enough? Oh my God, he's not eating enough. What's going on? You know, that can, what do you think about that shutting down their own hunger cues and being like, might not be a safe time for me to eat right now?
Yeah.
And that like almost making it like a vicious cycle, like, oh, mom's like freaking out. Maybe now is not a good time to eat. And then mom freaks out more because they're not eating. And, you know, like, do you find that that is like a dynamic?
1,000%. 1,000%. You have to, one of the things that we see, and one of our jobs as a clinician, the practitioner, is to be the calm. Okay. So even if they're in this like fight or flight, and we talk about all these, like there's fight or flight, rest or digest, like all these different kinds of things to look at the body. We're co-regulators. We feel the room, we feel the temperature, but infants are even more to that extent. So if we have a highly anxious parent, which postpartum brings out a lot of an important component of mood, perinatal mood disorders or anything like that. So if I have a type A parent that's already prone to being very regimented, and now they're worried about this, about getting enough, so that anxiety is heightened, that is a very primal and physiologic response in the form of tension, in the form of how they're communicating, handling baby. They'll be very different. I joke with them. I'm like, you know what? Let's have our poker face on. I know that we might be panicking right now, but we can't show baby that. I want you to talk to them. Tell them how good they're doing right now. Tell them how happy you are with them. Yeah. Like we might on the inside be kind of panicking and having alarm bells. But right now, what is happening is they are feeling our body. I say the same thing as well as a painful latch. A lot of times we get this, as long as my baby's eating or comfortable, I'll just grin and bear it. I'll just get through it. I'm fine. And then you see them all like this. And I'm like, actually, the more comfortable your body is, the more comfortable baby's going to be. So I'm like, it actually benefits you, and they can actually get more milk when they're more comfortable, better latched. You're going to be able to play off of each other. Baby's going to feel that. So if you're calm, I get them in position. I'm like, as baby looks really comfortable, take a deep breath, drop those shoulders. And that breathing is automatically going to try to like take our nervous system at that fight or flight response and start to calm down. So usually the parents, we're working on that regulation aspect and during an actual feeding, because it's such a strong factor, really.
Yeah. And even honestly, even in our picky eaters, we're always trying to bring down their fight or flight, bring down the cortisol and the stress, because when our body has cortisol rushing through it, it shuts down your digestive system. Because you know, when you were trying to escape a tiger, no one cared if you were hungry. You had to get the hell out of there. So it's the same system. So whether you're just stressed out because you're like nervous that they can't eat, or there's someone gonna kill you, a tiger's gonna kill you in 2 seconds, your body doesn't know the difference. It's the same hormones that would be shutting down all of the hunger cues.
Yep.
And I feel like that plays such a big role, and that's so like under talked about, or like, you know, like it's like no one cares that mom's stressed out. Like, well, you know, like just deal with it. Like just figure out a way to get them to eat, but it's like, no, like you can't, like mom can't be stressed out, because baby's gonna know that mom is stressed out.
They're gonna know. They're gonna know. And
they're not gonna tell you, but their body will feel it.
You can absolutely tell. Like that's why I say we all have a nervous system. We all have a sensory system. There's nothing inherently bad or good. We're not wired that way. We're not bad or good feelings, bad or good like responses to our environment. But what happens is that's gonna not only shut down digestion, but overall in skill building, whether it's play, feeding, any kind of learning. Are we better I always say, are you better to study when you're stressed or when you're in a calm place? We're going to learn better when we're calmer and we're more regulated. We can't learn and keep things long-term. You might get short-term gains, maybe, but long-term gains, especially with body work. If I have a baby that's like, my philosophy is baby shouldn't be upset, crying. If we have baby that's like a disgruntled employee and not happy with what I'm doing, I switch out of it. So a calm, regulated nervous system that feels safe is going to take activities so much farther than, say, just pushing through it. Keeping baby at the breast, they'll eventually latch. No. Reset, have mom and baby take a break, have the partner take the baby, calm them, and reset and reconnect again.
Yeah, that's a good suggestion. Just take a break if you're like at your like breaking point, like right, just take a breather, maybe go outside, take a walk, you know, just quick, like get out of the environment maybe and just start over.
Oh my gosh, yeah. It's there's so many nuances though. Yeah,
I know. Feeding's crazy complicated.
Yes. And I mean, if we had all day, I don't think it'd be enough time. But that is a little bit of what I think I really wanted to drive home about this whole umbrella term of body work, how our bodies, we're a bunch of little nervous systems, sensory systems in these bodies, and how we can prepare to just, this is also their first experience on an extrauterine life. So usually what I say is we want to set up for mealtime success for their lives. Okay. So this might be really stressful right now, but what we're doing is going to have long-term gains however we proceed. So that way you feel comfortable in responding to your child. And if I do have those ones that, oh yeah, my older one is picky, it's usually they're like, this makes so much more sense now. And
right, like they can kind of connect the dots
after
the fact. I know, I find that too. I'm like, oh, look at all these little red flags that I saw.
When we know better, we do better. And especially when our goal is to empower parents ultimately. That's really like informed decision making. We can give suggestions, but a family's going to do what works best for them in meeting their goals. So if they leave feeling empowered, and it might not be the exact recommendation, but that's how they feel like their family will thrive, all the more power to it.
Yeah, I love that. Oh, well, thank you so much. Now, where can people find you and all the great things that you're doing?
Okay. So I am on Instagram. I'm a little bit of a comedian, but I have fun with my reels. You can find me at nurturing_lift_OT. So LIFT is an acronym, lactation infant feeding therapy. You can look.
Yeah, I didn't even think about that.
Oh yeah. I'm just full of those, right? They can also, my website is www.nurturinglift.com. And what I try to do, so I have individual, like I said, only see really 0 to 6 months, breastfeeding, bottle feeding. I will do prenatal lactation support, and I've actually started doing pump series. So prenatal pumps, and really trying to help return to work on life is stressful enough, but then you throw returning to life after the 4th trimester and it kind of throws you for the loop. So I've kind of started making accessible little mini virtual and in-person workshops for those.
Oh, I love that. That's probably so helpful for people. I definitely would have done that when I had done that at the time. That would have been so helpful. I find that stresses people out so much of like, well, they got to start eating because I got to go back to work. Like, I can't tell you how many times I've heard that. Like, well, it's really important. Like that time crunch of like that starts to send the little cycle into a tailspin again.
Where it starts. Yes. So we try to I always say we're setting up from the very beginning, we're setting up mealtime culture. Like this is like, food is not a means to an end. It's beyond nutrition. For breastfeeding and chest feeding specifically, it's about that co-regulation and connection at the body. But we're just setting up for a lifetime of like a relationship with food.
Yeah. And it's like the most important relationship because you're going to have to do it every day for the rest of your life.
Multiple times a day. Yep, exactly.
Well, thank you so much, Bella. It was amazing talking to you. And please make sure you follow her. And of course, you can find us at foodologyfeeding.com and our courses and audios and YouTube videos and all of the things. So thanks for joining us.
Thank you so much for having me.
Thank you for listening to How to Unpicky Your Picky Eater. To learn more about achieving your child's feeding goals, check out Christine's website at foodologyfeeding.com. And be sure to tune in next time to How to Unpicky Your Picky Eater.